Thank you very much for that, Stefan. It's really a pleasure for us to be here today and be the fourth group presenting our joint statement. And I would like to dive right in with some background into why we thought it was important to have this thematic network in the first place. So you're probably all aware of it, but what we see is that the use of AI technologies, artificial intelligent technologies, or algorithmic decision tools in the health sector is rapidly growing. So that means, there's huge amounts of research going on in this area, but we also already see its application in clinical practice, for example, assisting technologies in diagnosing diseases, but also recommending therapies or in monitoring of certain conditions, for example, chronic conditions. So we see these applications coming in, and of course they can be really useful, but there's also growing evidence of risks to patients' health, their well-being, and their fundamental rights in the absence of some appropriate legislative frameworks. And we do recognize that a lot of efforts are going on at EU level to develop some of these regulatory frameworks, but there's just huge risks involved. For example, AI technology is always based around a lot of data collection. This data can be biased or incomplete, and there can also be privacy risks involved with this. In addition, there's risks to patients' informed consent and their autonomy, because it's often quite unclear how an algorithmic decision tool actually works and how it comes to its decisions. So there's risks involved with that. And then, of course, there can be malfunctioning of the technology, as well as simply some wrong or faulty outputs and outcomes. And then, these are just some examples of the risks. But key populations are at increased risk of harm due to this. And key populations is quite a broad term, but in this context, you could think of persons with disabilities, people experiencing mental health problems, people with insecure residence status, or racial and ethnic minorities, as well as the aging population. And they are at risk due to layering patterns of inequalities that relate to many factors that you can see on the slides. So we will dive more into this later, but first a little bit of background on our approach. Most of our work in the thematic network centered around two webinars that we held. In the first one, we really outlined the legal context of AI and health in Europe. And then in the second webinar, we gathered input from many different interest groups. Also, many people here in the room contributed to that. So thanks a lot. It was really valuable input that formed the basis of our joint statement, after which it went to extensive feedback procedures where we received input and feedback from many different organizations. So then on to the joint statements. The aim of our joint statement was to direct the use of AI in responsible, participatory, ethical, and equitable ways. And we took a cross-sectoral approach. So what that means, you can see this being displayed in this slide. So this is also kind of the structure of our joint statement, and these are the aspects that we focused on. We're not going to cover all of those in this 15-minute presentation, but we'll mostly focus on the implications for key populations, as well as some of the recommendations that we formulated. So then on to a little bit more the implications of health AI on key populations, before I hand over the words to Pin. So this figure I find particularly helpful in understanding how discrimination is feeding into AI systems and how that also has cascading effects. On the top left corner, you see the real-world patterns of health inequality and discrimination that just exist in this world. for example, unequal access to healthcare, but also discriminatory healthcare processes. And that those real-world patterns of discrimination are automatically represented as well in all of the data that we have on our health systems, for example, in medical records. And on top of that, there's sampling biases where often key populations are underrepresented in the data or not correctly represented. So then, on top of that discriminatory data, we have biased AI design and deployment practices. So, for example, AI technologies that don't take into account people's accessibility needs that they might have, but also AI innovation that is mostly directed at what is most commercially attractive instead of what's actually the needs of patients or needs of key populations. Those are often not taking center stage. And then in addition, there can be injustices in how these technologies are actually being used. For example, when they are accessible to a small group of people who could benefit from it, but not to another group. And then thereby it can deepen digital divides, exacerbate global health inequality, and also the rich versus poor treatment gaps. And then all of these aspects then again result in health inequality and discrimination in the real world. So this is a detrimental loop of bias, and it has major implications for key populations. I'd like to hand over the word now to my colleague. I can take it from here.
Thank you very much, Janneke, for providing a really great picture so far of where we are right now. And so if you have just looked at the previous chart, what you see is that we're extremely driven by data, right? And just take a look at this comment over here. When you have artificial intelligence that then feeds into this picture, what it does is it picks up on this existing data that manifests inequalities that have existed for centuries. It brings it out into the real world, and if we're not careful, it magnifies this all, right? What can we do? We need to reorient. We need to displace, think about how can we actually displace these power structures, right? Okay. How do structural inequalities permeate data science? How does it permeate artificial intelligence? Where along the pipeline do we see these problems creeping in, right? So when we think about health inequalities and the key populations that are affected by health inequalities, where does this come from? It doesn't exist in a vacuum. We've got to look beyond it. That means we've got to look at racism, classism. We've got to look at history. So there's lots of things that all comes together. It boils down to even simple questions. What kind of questions do we ask? What colors do we use in our presentations? All these have connotations, right? And so in our joint statement, what we're really looking at is to think about forgetting everything that we know. Moving past binaries, right? Creating or sort of taking and synthesizing new perspectives of prior knowledge and lived experiences of persons that are in part of these key populations. So the impact is extremely harmful on key populations here, especially because of the intersectionality. Now, just to give you a few examples, I don't want to go into them too much. Persons with disabilities, for instance. They've always been subject to ableism narratives. We need to fix them. But why? Why can't we just adapt? Why can't we help adapt around the ableism narratives, for instance, right? Persons with disabilities also have suffered coercion, segregation, forced treatment, institutionalization. Now, things like this. Now, if you pick up the data on all this in the health sector, for instance, what we're going to see right now is the data that repeats itself. So it has to stop at some point, somewhere, right? Now let's take persons with mental health conditions. I think because we're much more moving into a digital era right now, it's very easy for mental health to be affected by this little thing over here. You download an app maybe that helps you with your mental health. But if it's I was going to say a word that I shouldn't have said. If it is of very poor quality, for instance, sorry about that, right? It further exposes a person to harm, especially a person with a very fragile mental health condition, right? And most algorithms, most kind of apps that you see, it's all about fixing, detection, diagnosis. It tells you there's something wrong with you. It tells you that it's okay to use a technological fix. But mental health problems are so much more, right? They're extremely complicated. So these are just a couple examples. There's, of course, racial and ethnic minorities, Roma people, travelers. There are also persons who are undocumented, persons with insecure resident status. Data is being used for asylum, border control, migration. And it's difficult to even get access to some basic rights, right? But then it's even worse when your basic rights to healthcare is then tied to immigration and control, and using that as surveillance, policing, discrimination, violence, right? Sorry, I sound extremely like...
Passionate.
Yeah, so basically what we're trying to say is, look, we love AI, I love technology, I will die without it, but we need to be very careful about where we're going with this. It is not a neutral tool. Is it a neutral tool? Right? I think that's where we are right now. And if we look at it, we're really thinking about how co-creation, I know several others have also mentioned, and I think it's such a beautiful word, co-creation, is the way that we really need to be going, right? And AI itself can be extremely beneficial, but it fails to take into account, and we need to then take into account the multifactorial, societal, cultural, sort of environmental origins of all the problems that we have so far. So let me tell you a little bit about what our joint statement hopes to do. So we've got two main sections. One is about general measures for health AI, and the other is on specific measures for health AI and sort of targeting how we can help key populations, right? So the general measures are more broad in nature, and actually, I have to preface by saying, in actuality, there will be overlaps between these two. It's not a static process. It's going to be an ongoing process. But for ease of trying to make the joint statement as legible as possible, right? So if we look at the general measures that we've got so far, I'm not going to read all this because, well, first of all, I can't see that. But secondly, I think you can download the joint statement as well. We've already posted that up. Now, we're very focused in the general measures part about bringing the AI in health consideration to the fore, like throwing it in your face, essentially. And most of all, these general measures already requires complementarity with existing EU-level initiatives. We're not reinventing the wheel over here. We've got the GDPR. We've got the European Health Data Space. We've got the EU AI Act that's all being deliberated right now. The Medical Devices Regulation. We're not reinventing the wheel, but we need to strengthen the foundation that's already there right now. And so that's what our sort of general measures are, right? Now, moving on to the specific measures. Now, this is a little bit more reflective in that sense, right? And we basically try to identify the best that we can that would take into account the intersectionality arguments that I just spoke about for key populations, coming down to essentially co-creation, the community effect, the really incorporating the voice of key populations. And this has always been the intention of our joint statement, right? And I think one question that I also thought about during this entire process of drafting and dealing with our very esteemed stakeholders, I really thank all of you for being part of this, is, so are we looking at AI to be the panacea to reduce health inequalities? I think that's the goal. But before we even get there, we've got to think about how we can then reduce the inequalities first and then use the AI to then help us. At least that's where I hope we're moving towards, right? So we've got some early endorsements so far. And I think Ramon earlier mentioned that, when it comes to endorsements, especially those with boards, organizations, it's going to take some time. But we hope that you support a statement. Really, we're not seeing this as just, okay, this is a life cycle and that's it. It's going to be a permanent stakeholder network. That's our intention, in case everyone's interested to know. But what we also want to do is, we've realized that this is just the beginning, it's just the tip of the iceberg, right? AI is huge, okay? And what we're going to do, or rather we hope to do, is to investigate the co-mingling of health, AI, and key populations even more, right? And so what we hope to do in the near future is to think about, for instance, and this is our big plan, breaking down health AI, breaking down things into professional training, breaking it down to data collection methods. How do you label them? How do you collect them? Who collects them? Who keys them in? What kind of machine learning methods are you using? We break them down into algorithm bias, gender gap, racial gaps, medical data that's missing from women, right? And then you move down even some more, women of color, Asian women, Caucasian women, etc. So the layering is extremely intricate, and that's kind of our big goal over here, moving down this very intricate sort of layer, right? And investigation, and really thinking about how we make differences in terms of how we use AI, how we use data, and how we use digital technologies. Thank you very much, everyone.